Hello everyone and welcome to QuickMed, where medicine is explained quickly and easily. In this video, we will cover the three basic components of the urine analysis, which are your inspection of the urine, dipstick chemical analysis, as well as microscopy. We'll also cover the different findings that you can obtain from a urine analysis, as well as what they can indicate to us. Knowing how to interpret urine analysis can offer you very high-yield information, both in a clinical setting as well as on your test questions, so let's get to it. We'll first start with gross inspection, which is where we look at the color as well as turbidity or cloudiness of the urine. If you watched one of our previous videos on hyperbilirubinemia, you might recall that the heme found in red blood cells is broken down into bilirubin, which is then broken down into various components, one of which is urobilinogen, which is found in the intestine. Urobilinogen is then broken down into stercobilin, which is what gives feces its brown color. But another thing we didn't mention at that time was that this urobilinogen can also be broken down to urobilin, which is what gives urine its yellow color. The normal color of urine ranges from a pale yellow to a dark amber color, depending on how hydrated or dehydrated an individual is at the time. And just keep in mind that a urine analysis is a snapshot in time, so it indicates an individual's hydration status in the moment in which that urine sample was collected. So what are some things that we can see on gross inspection of urine? Well, the truth is the color of urine can actually be affected by a wide range of things, from food to drugs to infections. And so the color of urine is not always as useful as some of the other things that we can see on a urine analysis, but some things to keep in mind for test questions is that a red color, especially a gross, bloody red color, is concerning for malignancy. And a cloudy urine can indicate an infection, but it can also indicate that there are crystals present, particularly precipitated phosphate crystals in alkaline urine. Let's now move on to our second component, which is the dipstick analysis. And this is what you'll oftentimes see is done in an office setting when we collect a urine sample from patients, and it provides you with most of the information that you're looking for. In a dipstick analysis, what happens is we take this thin plastic tube and dip it into the urine. And after a certain amount of time has passed, typically about 1 to 2 minutes, we compare this tube with a reference standard to determine the concentration of the analyte that we're measuring. And so the color change that you see on this tube indicates both the presence and the concentration of a particular substance. And so you'll see something that looks a little bit like this. Let's now go over some of the different test results that we get on a dipstick, starting with the urine-specific gravity. This indicates a person's current hydration status, as we mentioned before. A normal value is around 1.010. If it is greater than 1.020, this indicates a more concentrated urine, and this can indicate dehydration, increased glucose in the urine, as well as SiADH. If the value is less than 1.003, this indicates urinary dilution, and this could indicate diabetes insipidus, water intoxication, among other causes. And so you really have to correlate clinically here. Our second test result is pH, and urinary pH is often between 5.5 and 6.5. This information is not usually as useful, but think of kidney stones because that's oftentimes where pH is mentioned on test questions. We'll now go through some of the other test results that are oftentimes very, very useful. So we'll start with the bilirubin, which in this case here is going to be your conjugated bilirubin, remember, because that is your water-soluble version of bilirubin. Seeing bilirubin on a dipstick can indicate that there is hepatobiliary disease, and keep in mind it can be your intrahepatic or your posthepatic because the liver is responsible for conjugating bilirubin. Seeing glucose in the urine can indicate diabetes, and particularly when your plasma glucose concentrations exceed 180 to 200, that is oftentimes when our transporters are overwhelmed, resulting in glucose in the urine. Another cause can be SGLT2 inhibitors, which are medications that are used to treat diabetes, among other conditions, and they work by inhibiting glucose reabsorption in the kidney, and so you can often see this as a side effect. Seeing ketones in the urine can be indicative of DKA in the right clinical setting, as well as inadequate nutrition because it indicates that fat is starting to get broken down, producing ketones. Leukocyte is another finding, and it is produced by neutrophils, and so it can indicate an inflammatory process like a kidney stone as well as infections. Nitrites are created by nitrate-reducing bacteria, and so their presence actually has a higher specificity than leukocyte esterase for detecting a UTI. And any discussion of dipstick results would not be complete if we did not mention protein and blood, which will be discussed in our next slide. So protein in the urine is known as proteinuria and is an abnormal finding because nobody should have protein in their urine. The differential diagnosis for proteinuria is broad, and there are some benign causes, so it's not always concerning, but it is something that needs to be considered. Some of the more benign causes include orthostatic proteinuria, which is where you have a change in protein excretion depending on body positioning, and so typically an upright position will lead to an elevated protein excretion compared to a supine or recumbent position. Some of your more concerning causes of proteinuria indicate that there is kidney damage, and this can be either in the glomerulus as well as the tubules. And there's also overflow disorders, which is where you have increased protein concentrations in the bloodstream, and this overflows into the urine. So think of multiple myeloma in this case. And just keep in mind that whenever we do have proteinuria on dipstick, we do need to confirm the presence of the protein as well as the concentration of it if it is present. And this is done with a spot urine albumin creatinine ratio. And now we'll go over our final dipstick test result, which is blood. Dipstick testing for blood detects peroxidase activity of red blood cells, so it has a pretty high sensitivity for detecting hematuria. And this source of hematuria can occur anywhere along the urinary tract. It can occur within the glomerulus itself, as well as other renal causes like polycystic kidney disease or sickle cell disease. Your urologic causes can include issues with the bladder or the prostate, and then there's also your other causes, and this is most often as a result of trauma. Just like with protein, when we do see blood on a dipstick or hematuria on the dipstick, we do need to confirm with microscopic analysis because this is where we get a lot more information. And this brings us to our third component of the urine analysis, your microscopic analysis, which is where we take a urine sample and we analyze it under the microscope. While microscopy is part of the urine analysis itself, it's not often done in an office setting because it does require additional equipment. It's often done in an inpatient setting, however, when the dipstick is abnormal. So let's start with our first scenario that we just discussed, which is where you have hematuria on dipstick and you obtained a microscopy to confirm. If you see 3 or more RBCs per high power field on microscopy, this is confirmatory for microhematuria. And once you've confirmed microhematuria, the risk of a GU or a genitourinary malignancy is 3% in these patients. And so in the appropriate clinical setting, cystoscopy and imaging can be recommended to rule out those causes. Let's now move on to our white blood cells, and neutrophils are the most common white blood cells that we find in urine, and they can indicate an infectious or inflammatory process ranging from UTIs to STDs to kidney stones. Epithelial cells are another finding that we can see on microscopy, and it's good to know that squamous cells line the distal 1/3 of the urethra as well as the vulva. And so if you have more than 5 large squamous cells per high power field, that can suggest contamination. And it's necessary to keep this in mind because if you have a contaminated urine sample, and you have abnormal findings, it makes you wonder, is this due to an infection or due to the contamination itself? And finally, bacteria is something else that we see on microscopy. It can be present with both an infection as well as contamination, as we just mentioned, so it's important to look at the symptoms of the patient as well as the other values that are present when making your diagnosis. Let's now move on to something that's a little bit more visual, which is the crystals that you can find in urine, and is what we often see when a patient has kidney stones. Our calcium oxalate stones are your most common kidney stones, and they have this envelope shape to them, and so you can remember them as having like an X in the center, consistent with the X in oxalate. Your ammonium phosphate crystals or your Struvite stones have these coffee lid appearance to them, as you can see here. And the cystine stones have 6 sides to them. They have a hexagon type shape, and so I think of cystine, 16. And your uric acid stones have this more rhomboid shape to them. Another finding that we can see on urine analysis are your casts, and the presence of casts in urine suggests certain renal pathologies. So let's go over granular casts as well as renal tubular epithelial cell casts, which are seen in your top 2 pictures here. So the presence of these casts can indicate tubular injury, such as acute tubular necrosis. And this is pretty high yield for your test questions, so make sure to keep this in mind. And in the bottom 2 pictures, we're seeing your white blood cell casts as well as your red blood cell casts. In most cases, these casts are going to originate from the glomerulus, or they indicate that there is injury to the glomerulus. So typically we will see these casts in cases of glomerulonephritis, but we can also see white blood cell casts in cases of interstitial nephritis, which is also high yield, as well as pyelonephritis. Now that we've run through all the material, let's summarize what we've discussed. We discussed that with the urine analysis, there are 3 basic components: your gross inspection, and this is where we look at the color of the urine as well as the cloudiness of the urine, and it's not usually as useful as our other 2 tests. The second is your dipstick, which is a very quick and easy test that we can do, and it offers you a good amount of information. It can tell you if there's glucose in the urine, blood, or protein, as well as any signs of inflammation or infection, like with your white blood cells, your leukocyte esterase, or your nitrites. And the third component is our microscopic analysis, which is not always done in an office setting, but can be useful to confirm the results that you see on a dipstick and also provide you with additional information as well as where exactly in the urinary tract are we having the problem. Alright everyone, we hope you found this video helpful. If you did, please make sure to like and subscribe so that we can keep doing what we're doing. And as always, good luck studying everyone.